Good afternoon, everyone, and welcome to this month's Climate, Environment, and Health monthly webinar series hosted by the MGH Center for the Environment and Health, the MGH Institute of Health Professionals Center for Climate Change and Climate Justice and Health, and Brigham and Women's Hospital. I'm Greg Fury. I'm the Medical Director for Climate and Sustainability at Brigham and Women's. And it is a real privilege and an honor to introduce today's speaker. So Victor Zhao is the President of the National Academy of Medicine, Vice Chair of the National Research Council, and the James B. Duke Distinguished Professor of Medicine at Duke University. He's recognized globally for a long and highly decorated career as a physician scientist, administrator, and leader. And Zhao is known for his seminal work on the renin-angiotensin system and pioneering research in gene therapy for vascular disease. He was a medical resident and chief resident at Brigham and Women's Hospital, and then a cardiology fellow at MGH. And in 1990, he became chief of cardiology and later chair of medicine at Stanford. In 1996, he returned to the Brigham as Hersey Professor and chair of medicine, and during his term, he founded the divisions of global health equity and women's health, among others. Dr. Zhao served at Duke University from 2004 to 2014 as Chancellor and CEO of Duke Health System, and then became the president of the National Academy of Medicine, where he leads a strategy of innovation and equity. Under his tenure, the National Academy of Medicine has launched important initiatives, including the Global Health Risk Framework, the Human Genome Editing Initiative, and the National Academy of Medicine Grand Challenge in Climate Change and Health, which we'll be hearing more about today, and which is aimed at reversing the effects of climate and health by mobilizing the biomedical community to drive changes. Among his many honors are the Gustav Nyland Medal from Swedish Royal College of Medicine, the Ellis Island Medal of Honor, and the Henry Frison International Prize. Dr. Zhao has received 19 honorary doctorates. So without further ado, I'll turn it over to our distinguished guest, Dr. Zhao.
Thank you, Greg, and good afternoon, everyone. I guess it's past noon. What an honor it is to be asked to speak to my old haunting ground, my second home, if you will, which is the Mass General Brigham. I grew up there. I spent 25 years in Boston between MGH and the Brigham. And so when you call, of course, I say yes. And today, and the topic that you have chosen is so important, Climate, Environment, and Health series. And I'm just so honored to be able to give this part of one of the lectures for the series. What I want to talk about today is to make a case for collective action for the health system. And you'll hear from me the idea that because all of us in healthcare, whether it's in healthcare delivery or supply chain or education, should all work together to address the issue of climate change because it impacts health and equity. May I have the first slide, please? This is the face of climate change. And, when you look at public information, news media, literature, they usually characterize climate change as an environmental impact that's of great concern, and it would greatly affect our future generations. And you'll see an image of a polar bear on the shrinking, melting slab of ice. But what they're missing is this picture, which is affecting human. This is the human dimension of climate change. After all, this is, to me, the most important issue because people are suffering, dying from the results of climate change. Next slide. Here's some data. Next slide. Oh, here's what we do know of climate change. As you can see, extreme weather, heat stress, air quality, water quality and quantity, food security, vector-borne distribution, and you name it. That can lead to a series of climate-sensitive health risks that includes heat-related stress, respiratory disease, and of course, such as asthma, COPD, vector-borne diseases, zoonosis, and waterborne disease, malnutrition, NCDs, injury, and mental health, of course, and many others. So climate change can impact health in many different ways through these exposure pathways. Next slide. And you all know that, of course, it's already greatly impacting human health, and it's, to me, a public health crisis. Because by the recent report, McKinsey, that was released, they predict that by 2050, 14.5 million additional deaths to climate-related events, which brings it well over 20 million by that time. They relate to heat, food, drought, tropical storms, fires, the things I just mentioned. Even right now, extreme temperature are causing 5 million deaths a year. Air pollution from fossil fuels, 5 million globally of mortality, vector-borne disease, and of course, many others. But it's not only the deaths, it's the morbidity. 80% of all health impact of climate is in morbidity, and of course, this NCD, mental health, and many others. So you can see that this is truly a public health crisis. It's also costing health systems over $1 trillion, and economic and social impact by 2050, as estimated by the McKinsey report, is 12.5 trillion economic losses and up to 1.2 billion climate refugees. These are astounding numbers. Next slide. So I would declare, as you all know, you agree, that it's a public health crisis, but it's also an equity crisis. And in our NAM strategic plan, we have put this as one of the top priorities that we must work on for the next 5 years and beyond. Next slide. Now, why is it an equity crisis? Well, if you look at globally, richest 1% are responsible for twice the emission of the poorest 50%. In the World Bank report, 31 low and middle income countries account for less than 0.5% of global carbon dioxide emissions combined, but the top 3 emitting nations, including, I'm afraid to say, US, accounts for 50% of the emissions. And so we do the most emission, and of course, the impact negatively is in the low-income countries, 6 times more likely to be affected and 7 times more likely to die compared to high-income countries. Why? Because these countries have populations who live on the land, agriculture, forestry, fishery, cattle, and they're most affected by climate change. Furthermore, these communities do not have the benefits as we do from healthcare insurance, basic health services, infrastructure, and are most vulnerable to shock hitting their income streams. Next slide. And of course, globally, when you think about all this, it's really, really impacting development, economic development, and others. As you can see in this slide, it depicts, of course, the impact on productivity and, of course, on the livestock crop losses, so that by 2023, the number of people living in poverty may be up to 122 million, and it's affecting Sustainable Development Goals, SDG, none of which can be met the way we're going with climate change. So I think we're going to see a tremendous shift overall globally in terms of equity and well-being, particularly in the vulnerable population. Next slide. Now, we're not immune from this. US is certainly affected by climate change. If you look at 2023, it was the hottest year on record. There were 28 confirmed weather or climate disaster events, exceeding 1 billion loss of economic loss to date. And they include drought events, flooding events, severe storms, cyclone, hurricane, wildfire, and of course, winter storms. And of course, if you look back in the United States, in 1980 to 2023, the average is 8.5 events a year. But if you look at the last 5 years, we're now dealing with 20.4 events a year. Who said climate change is not real? Next slide. And of course, this slide shows you that the illnesses of air pollution, heat-related illness, extreme weather events, vector-borne disease, mental health is affecting everywhere in the United States. Next slide. And of course, as I said, in the United States, just like globally, there are vulnerable populations. Those communities who are poor, those communities of color, older adults, and children. So obviously, it's also having an equity issue because they have equal risk and impacts. Next slide. So if you look at the United States, and look at weather events and vulnerable communities, you can see clearly that it is those poorer communities and those people who have existing disparities, economic, social, and medical disparities, who will most likely be impacted. Those, as I said, those counties cope very poorly because they don't have infrastructure, inadequate power supply, lack of transportation, you name it. And of course, if you look at hurricanes, we've seen tremendous impact. You know, I always kind of think about the image of Katrina and how those communities which are greatly affected have really lack of transportation and having hospitals being affecting older adults, African Americans, and many others. So you can imagine that in our country, we're certainly seeing those communities which are greatly affected by climate events. Next slide. And if you consider that together with environmental issues, as you are interested in as well, you can imagine those communities which are impacted. For example, I just gave you some examples of environmental injustice. They are in communities of poor socioeconomic situation, frequently of color. Katrina, I mentioned. Black snow in Tahoe Key in Florida, which is in the Glades. And as you know, they burn every winter and spring, they burn sugar canes, in order to, in fact, get rid of the outer leaves of the sugar canes. And they release harmful smoke, which are looking white, which are like black smoke. And it turns out, of course, in this area, a third population live in poverty. Communities are mostly Black and Hispanic, and they have 4 times the average air pollution levels. Cancer Alley in Florida, this is a long 85 miles along the Mississippi River from, all along Mississippi River, from Baton Rouge to Louisiana to New Orleans. They have suffered high levels of air pollution and therefore resulting in cancer rates in some areas which are 500 times of the others. And of course, if you look at Asthma Alley in Bronx, that's another example of poor area where there's a lot of industry pollution and high level of asthma. And I can go through the list more and more. Next slide. So I think I've made the case that climate change is one of public health crisis and equity crisis. And our sector, you, really are closely linked to this issue because, first of all, we are responsive to health and weather emergencies. We also care for weather-related illnesses, which are chronic illnesses. But also, importantly, we develop health system and help community develop resilience. Next slide. So, for example, if you look at health system preparedness resilience, which we must be prepared to be able to respond to climate change and also prevent them in terms of health crisis, we have to strengthen climate resilient primary health infrastructure to promote disease prevention. We have to have surge capacity to respond to extreme events. We have to promote new technology models of care, which I'll talk about later, to reduce our carbon emission. We have to look at disease surveillance, monitoring efforts and others. And of course, we have to communicate and educate the public and community in terms of getting ready. So health system plays a really important role in looking at preparedness and response. Next slide. But we also are the anchor institution. Look at MGB. You are the major institution employing a huge number of people in your community. And we must play a much bigger role in helping community to build themselves, to be more ready, to have infrastructure. And we have to address social determinants of health to improve community ability to adapt and recover from disruptions. Next slide. So you can see our responsibility, but I want to go one more step to recognize that we actually are the culprit of carbon emission. You probably know that the health sector in the US emits 8.5% of total carbon emission. That's huge. And US alone accounts for 5% of carbon emission, globally in the health sector. And we emit because of the following. One is operations of healthcare facilities, scope 1. Scope 2 is that we purchase energy, heating, and cooling. And scope 3 is that we actually work with industry to get the supply and supply chain with the transportation, manufacturing emits huge amount of carbon. So all told, 8.5%, of which scope 1 and 2 that we are responsible for is about 10 to 20%, no more than 30%. So there's a lot of work we have to do. So first of all, not only do we need to care for climate change, emergencies, and others, we must do no harm. And the health damages from US health pollution is estimated to be on the order of, believe it or not, preventable medical errors, which we, of course, IOM is known for generating the original report. Next slide. So how does the health sector contribute to climate change? Well, everything that we do, our buildings, our facilities, heating and cooling, our high energy consuming equipments and high carbon emitting equipments, our waste production and waste and treatment, anesthesia gas and inhalers, and of course, many plastic and rubber products, the catering, the food that we eat, especially red meat, pharmaceutical and chemical, and of course, transportation. Tremendous amount of transportation for ourselves, but also for supply chain, and of course, business travel. Next slide. So if you look at, believe it or not, the operating room, ever go and visit one of them? You should. If you look at the piles and piles of disposables, the operating room consumes 3 to 6 times more energy per square foot and generates 30% of overall hospital waste. The disposables, gowns, and all the things, gloves and others, are accounting for a huge amount of waste, which result in carbon emission as they are being incinerated, etc. Social supply chain, 60% of the hospital supply chain costs, and 82% emissions from supply chain, as I said, and disfluorine and other nitric oxide are those gases which cause greenhouse gas emission. And so we have to take responsibility for these areas. Next slide. So what is our responsibility? First, being the trusted profession, we have to communicate to the public. This is a public health and equity crisis. So that more and more people are going to take action and support the action towards climate change mitigation and adaptation. Second, of course, is reduce the impact and improve health for all, particularly looking at climate-related disparities. Third, of course, respond to emergencies, as I talked about, and build community resilience. And fourth, do no harm. We have to reduce our carbon footprint. And finally, we have to accelerate research innovation at the intersection of climate, health, and equity. Next slide. So what do we need to do? So a few years ago, it became very obvious to the National Academy that we need bold and great ideas working across disciplines. We need to create public-private investment, and we need a lot more funding to look at research and actions towards climate change intervention. Next slide. So this is where we stepped in. The National Academy of Medicine, as part of the National Academy of Science, Engineering, and Medicine, the three academies are neutral, independent convener, and we are trusted messenger. I've launched, since I've been there, the idea of a grand challenge to inspire the nation and the world to coalesce around priorities, an audacious goal, so we can address these things together in science and medicine. Next slide. For those who are not familiar with us, we were founded in 1863 as the National Academy of Sciences. And over the last 160 years, we have evolved into three academies: engineering, science, and the National Academy of Medicine. And what we do is we convene, report, and catalyze, and in this case, agenda influence policy in health and medicine. and many of MGB faculty are members, distinguished members of our academy. Next slide. We have worked on climate change for a long while. You can see the many reports that we have generated. Next slide. And what we wanted to do here is to launch a grand challenge. In 2020, we launched this grand challenge, which is chaired by Dr. Judy Roden, who's the former president of Rocket Foundation and former president of the University of Pennsylvania. And we have now a true public-private partnership with about 200 collaborators across the networks. And we partnered with the Secretary of HHS and also the Office of Climate Change and Health Equity at HHS. And she's a co-chair of one of the collaborators with me. We have private industry, pharma, medical device supply chain. Of course, we have hospitals like MGB, many others, and academia, and of course, education and many others. And our idea is to have first communicate this as a public health and equity crisis. Second, catalyze the entire US health sector to reduce its carbon footprint. Third is to look at how to change the systems that includes agriculture and energy, transportation, to work together to look at climate and health, accelerate research innovation, and reduce inequities. Next slide. And so this grand challenge is to improve human health, well-being, and equity. So we have 5 strategic programs. They're all 5 programs which are working together, and they include the programs which reflect our strategic pillars and directions. I want to highlight these programs to you by telling what we do and ask you to join us. Next slide. First, you as health professions, still we're the most trusted despite the recent kind of COVID impact on information, misinformation, mistrust. So we have to be well educated and communicate this to the public, to our patients, and to ourselves, so that we can actually practice, efforts that can reduce carbon emissions. Next slide. So in this communication, we want to equip all health professionals to be effective messengers. So with the WMC, David Scotton, the president of WMC, with the Associate Nurses Academy, and with others, with dentistry, etc., we're now working towards a curricular reform against health profession for all health professions, so they are not only familiar with this and can become good communicators to their patients and public, but also practice what we can do in reducing carbon emission. We coordinate with the Climate Crossroad, which is a national academies across all 3 academies, to work on communication, and we work with partnership with networks and public partner communication activities globally as well. Next slide. In terms of the second program, we are actively looking at the understanding that agriculture, food, transportation, energy, water, all these things are affecting climate change, but rarely do they ever look at what they're doing to health and human well-being. So we are, with Judy Roden's and Andy Haynes' leadership, we created an international commission to bring together leadership of all these sectors to work together to look at, while you're looking at what you're doing in your intervention for carbon emission, take a look at what you're doing to health and how can we work together so that all policies, decisions have a health lens. So that's what we're working on at this point of time. Next slide. And in communities, we want to work with marginalized communities, which are really rarely engaged in decision-making. They have no voice. So we created this network, which will bring together vulnerable communities so that they have a voice, and they sit along with, if you look at the approach, the third bullet, government, academia, philanthropy, industry. So EPA, HHS, Department of Energy are all at the table with these vulnerable communities to understand what their problems are and to look at the challenges, to co-design solutions and offer them resources to actually address their issues in climate change. So our ideas will be to integrate community voices into research planning, prioritization, decision making. We are now engaging youth in the communities to collect stories and to be citizen scientists and to do a thing called photo voice, to take pictures and narratives to add to the data, to influence policymakers to take action. And so you can see that we are looking at surveillance, intervention, education in the community. Next slide. So how do we recruit this? We use a heat map approach, climate environmental justice score, developed by University of Maryland, which look at all counties in the United States and look at which are the ones with the greatest impact by climate environment. Then we overlap it with socioeconomic issues and selected some 20 such states programs, which are mainly community-based organization to working with communities on this issue. As you can see, Southwest, Midwest, Northeast, Southwest region, aligning on those in the map, and they're now working with us to look at those issues of how to help communities to address this issue, including awareness of resources from charity foundations, as well as government resources to help them address these issues. Next slide. Because research innovation, which is where certainly MGB comes in, big important opportunity to look at lots of gaps in research. We're now working on a research gap analysis and creating a research agenda to look at what are those issues. For example, particularly insufficient funding, silo and fragmented research, and of course, the false dichotomy between adaptation, medication. We need to do both. So we're looking at ways to link between climate change, human health and equity, looking at causal relationship, utilizing artificial intelligence and horizon scanning to look at emissions. We're looking at the issues of entrepreneurship to get more people into finding ways to reduce carbon emission, particularly in packaging, supply chain, looking at, of course, equity issues in community, and looking at a lot more funding, bring together the funding agencies as well as the NIH and others, look at how to fund things together in a more coordinated way. Next slide. So we're building a research agenda. You can skip this one. Next slide. And so I want to talk a little more time on this one here, the remainder of my time, which is decarbonizing your health sector. So together with my co-chairs, we wrote this paper in the New England Journal of Medicine about the need to decarbonize U.S. health sector. Next slide. So the way we have developed this, and let me give a shout out to Renee Sellers, who's of course is a member of MGH and MGB. She's leading this whole cooperative from New England Journal Medicine group to look at climate change. She's a member of our steering committee meeting on Action Collaborator and distinction member of our academy. The way we've organized it is we look at how to look at improve health outcomes by decarbonizing the health sector. We have a steering committee, and their co-chairs are myself, the Assistant Secretary of Health from Health and Human Services, former Chairman and CEO of Cardinal Health, the supply chain, and Andrew Whitty, CEO United Health Group, the big commercial insurance. And together we have a steering committee that's made of Don Berwick and John Perlin, the head of the John Commission, and many others. And we divide ourselves into there's 4 working groups. Look at what do we do with healthcare? How do we look at supply chain? How do we do education? And how do we create incentives and policy to help decarbonize? And so our members contain clinicians, hospitals, payers, distributors, academia, educators, nonprofits, and the government. Next slide. I'm going to go through quickly with you what we're doing, because here's where I think collective action from all of you joining us is going to be really important to make this happen. So first, healthcare. I already mentioned that healthcare delivery, through its work in, healthcare delivery, carbon emission, cooling systems, and of course, lots of waste, is really causing a lot of emission. So far, very few hospitals are working actively on this because there's a lack of business and financial mechanism. When I talk to CEOs, they say, one more thing to do. I already got enough hands full between COVID-19, nursing shortage, doctor shortage, and healthcare delivery and quality and safety. I don't have enough time. Besides, it's going to cost me money. And then I'm going to have to measure how I'm doing, and one more measurement. And so that it's most of them are not motivated to do this. So what we have to do is to find a way to motivate them, to help them, to give them incentive, to help them develop pathways, and to have view in the grassroots effort to say it's important to us, important to our patient. So let's all work together to make this work. So policy and regulatory changes. Next slide. So what are those examples? Well, first of all, we should take a look at how we deliver healthcare. We can redesign this altogether. If you think about the times your patients have to come into your clinic, as you know, we used to work at the Brigham. I can tell you one time I clocked myself to get around Longwood. It took me half an hour to get one end of Longwood to the other. And to think about the time and the energy needed to bring people to see you. Since COVID-19, we learned a lot about virtual care, and I know you're doing a lot of that. I think we can redesign a lot of areas of healthcare delivery to promote sustainability. Telehealth, digital care, community care, non-invasive measurements, and new models of care. I think we also need to think about how to educate patients, public, and prevention as well. And I'm going to talk a little bit more about cost effectiveness later on, but you will be surprised. There's good data to show that over time, by changing energy to alternate forms and practicing low carbon emission, actually there's savings to the hospital rather than more cost. And of course, we want to create evidence-based and create incentive for your frontline workers, just like in patient safety and quality, to be able to look at what are we doing in climate change and carbon emission. So shifting the care delivery to prioritize prevention wellness, embracing a circular economy with supply chain, that is to reduce waste, to look at more disruptive technology, and to look at low emission choice in the CO gas and inhalers. Next slide. So here's how we're starting this. We now have lots of hospitals who have joined us. And for those who have not started this journey, we say, first, establish an executive level sustainable team. You need team people, just like in patient quality and safety. You need people at the executive level buying this. Then you need to do an inventory. How much emission are you actually producing? Then establish decarbonization goals, and then develop a plan. That's step one. So really more in planning and getting the baseline right. And step two, begin to build, reduce building emissions, reduce anesthesia gas, this fluorines, and pressurized metered dose inhalers, reduce physical waste, reduce emission from food services, reduce transportation emissions, and start looking at electrifying your vehicles. Next slide. So those are the kind of things that you can do almost immediately within your own practice and within the hospitals to look at how can we actually contribute to those changes. And many hospitals are beginning to organize their ways of thinking about redesigning care, looking at circular economy, reducing waste, and many others. The second working group is on communication education. I already mentioned is led by the education certification bodies of medicine, nursing, and dentistry, pharmacy, and others, and other healthcare workers. What we want to do is empower healthcare workers, learners to advocate for decarbonization and to practice decarbonization. So first, we are beginning by looking at knowledge gaps. We're looking at support for education. We now begin to look at curricular changes and begin to introduce this. And so there's a lot of work to be done. Next slide. The group on supply chain, which is made of industry, mainly from companies about tech, pharmacy, supply chain, etc., they together realize they are the major emission. So they have to come together. And the good news is they're working under this public-private partnership to look at what are the issues and begin to look at, as you see in the third bullet, metrics, because there's inconsistency in reporting metrics. And then there's few innovations for incentive for innovation. So they begin to look at ways to standardize measurements and standardize reporting and to try to create more innovation, to look at new ways of supply chain. So there are many possibilities in this sector to work together. Next slide. What they begin to do is to do a journey map. This is already posted on our website, which they look at. If you want to get a supply chain, you want to enter into this decarbonization journey, the step one, which is understanding, navigating the regulatory landscape. Step two is to create an organization planning, as I talked about. Step three is to track what you're emitting. Step four is to tackle what you're emitting. Step three is continuous improvement, and it goes in a continuous journey map. And this is what they have published and have begun to implement. Next slide. Now, this group is particularly important because, as I told you, the CEOs are saying we don't really have enough time or resources to do this. So this is chaired by Don Berwick, that you all know, the previous, still with IHI, but one of the gurus in healthcare quality and safety, and also with John Perlin, the Joint Commission CEO, and Liz Fowler, who's the head of CMMI. Together, they're looking at how to create incentive, how to finance this, how to create policy, and how to measure together. So, for example, John Perlin is now introducing the IDIS certification to hospitals with Joint Commission. Look at whether they are begin to measure and practice, low carbon, green health care. They're not at the point of doing accreditation yet, but obviously over time, just like patient safety and quality, this can happen. And we're also financing with Liz Fowler, thinking about how can CMS and then with our insurance collaborators provide incentives to support decarbonization. Certainly, we do know that the government, Biden administration, have the Inflation Reduction Act that can help facilities to take money to create low carbon and no energy sources. But there are many other financing mechanisms, including, as Liz Fowler is thinking about introducing value-based care to measure emission as one of those, whereby you can get incentives through payment, and many others. Next slide. So they are working very hard on this. As you can see already, they have payment and financing, healthcare supply chain, healthcare delivery. They're looking at all those oversight in these areas and creating a series of publications, you can see, in enabling people to take advantage of financial resources and convincing Congress and others to create more incentive for healthcare systems to be able to go into decarbonization. Next slide. And finally, we're working with many organizations that already is working in the decarbonization space. Healthcare Without Harm, Kaiser, IHI, that I mentioned about Don Berwick's institution. The White House had a pledge which MGB participated in to decarbonize with a pledge towards net zero by 2050. The Office of the HHS of Climate Change and Health Equity, Joint Commission I mentioned, and of course I also mentioned Renee Salas program, a New England Journal of Medicine group cooperative. Together, next slide, with launching a major movement across the country. we are launching a movement so that all healthcare organizations can join us. Education, healthcare delivery, and others can all join. This is followed from Don Berwick's model of waste no will. When he started the 100,000 lives, when you remember 20 years ago, the NAM, then called IOM, produced a report called The Air's Human to say 98 deaths are dying from medical errors every year. Now it's up to 300,000. Don Berwick started this idea of a campaign, and he started a 100,000 lives campaign and brought everybody under 10. Of course, you know the rest is history. So we're trying to do the same thing to bring more and more people under this movement. And we'll be launching this on Earth Day in April. And already we have over 300 joining us, and we're now reaching to another 600 or so. And I know the MGB will be joining us. And please, all of you, do everything you can to mobilize anything you can imagine in the health system to join this movement. Because only through this movement can we realize the real outcome, just like we've seen at quality and safety. Next slide. Oh, so I want to end by saying climate change impact is a global problem. United States, but also everywhere. You've seen in Afghanistan, the flood, Africa, the drought, California, the wildfires, India, the extreme heat, in Philippines, the hurricanes, and of course, everywhere else. Next slide. So we're also working globally. And the way we're working globally is to work with regions and different geographic regions and local, because it's difficult to work on everything because there's no one size fits all. The contexts are very important. The solutions are different in different parts of the world. We move away from donor-recipient relation. I give you money and I'm the donor, instead into partnerships, as we're also doing with communities, United States. We want communities to own it and not owned by us. We want to strengthen the local capacity. So it's a bi-directional partnership, empowering with evidence, equitable partnership, capacity building, and of course, data is so important. So I'm asking that you join all of us to collectively address this issue. Next slide. So my final slide, in summary, climate change is a slide before that, please. Climate change is a public and equity crisis. I hope I've convinced you, probably none of you need to be convinced, that it will continue to have profound impacts on human health and well-being if left unabated. That we need new approaches to policymaking, research, innovation, and financing, and that we have to work across all sectors. First of all, within the health sector and across sectors beyond health and agriculture, energy, transportation, you name it. And the health profession, you have a great role in understanding, communicating, and acting as trusted messengers and leaders in this issue. So thank you very much.
Great. Thank you so much, Dr. Zhao. I want to start off by just showing our gratitude for this wonderful and inspiring talk, and really helping us understand how the National Academy is working to coordinate efforts across the health sector to drive change in a way that's going to be beneficial for patients and the planet. So thank you so much. We definitely have some questions from the audience that we'd love to get to. I may start off with a question of my own, if that's okay. You mentioned the need for incentives to drive change in the health sector. And I think from the perspective of those of us who are working within our own health systems, a question that commonly comes up is, how do we really begin to change culture within our own health systems? And so given that you have robust experience as a leader of both hospitals and clinical departments, I'm wondering if you might share some advice about how we can motivate individual health professionals and all of the staff at our hospitals to really embrace this idea of sustainability and begin to think of it as a core feature of their job.
Thank you, Greg. That's an excellent question. So I think this whole approach has to be top down and bottom up. As you said, everybody should care about this issue, but the C-suite need to provide the support for this. And I think we learned a lot from, I mentioned again and again, the Patient Safety and Quality Initiative. 20 years ago, IOM reported that we are having a lot of medical errors, deaths from medical errors. I was a young man then. I remember sitting at the Brigham as a faculty member when they came to give us a report, and I said, nah, it doesn't happen. Of course, we now realize how much it happens everywhere and mistakes are being made. But we said, to err is human. It's not an individual error, it's a system error. System has to support the individual healthcare workers. So therefore, we need to have system level changes and use the word culture. People have to buy it. So what happened since then? Well, if you think about this, first of all, we're measuring this. You can't improve what you don't measure. So then you have measurement, and then you provide both incentives as well as, of course, the metrics, external metrics to say, are you meeting those quality, etc. So it's a little bit of both. But as far as incentives concerned, I think it's walking the talk. And so I want to give you examples of patient safety quality. I know that MGH Institute and all of you guys are involved with many initiatives to say, how can we improve quality? Think about how you got there, right? It became a culture. How do you reduce safety? I know for sure that how we did at Duke, we faced some major medical disasters when I was there, and we made a major effort from the board level to the frontline level to say, this is really welcome. We're measuring everything. But more importantly, we provided financial incentive. What do I mean by that? Well, first of all, we actually created an innovation fund. And that innovation fund allowed frontline workers to say, you know what? I see something not right about this. I'd like to do this. And we give them a small grant to do this. And this grant can expand into a larger project in which it would be embraced by the hospital administration as one of their strategic directions to actually end up putting a lot more resource into it. So we have both incentive, small incentives, $10,000, whatever, to medium-sized incentive to bring in actual venture people to look at how we can monetize some of the new ways of digital approach to looking at hospital incentive. I think this can be done in climate change. If you think about waste, for example, every time a frontline person say, wait a minute, I'm wasting this stuff. I can do this, I can reuse it, I can do this or that. There's a lot of things you can do and think about virtual care, many others. Provide incentive for those kind of innovations to come in to say, Greg, to your CEO, I have a proposal that we can actually do this. It will improve patient health care and save carbon. And I think then if I was CEO, I'd say, yeah, I tell you, I'll give you some money to do a pilot. And this encourage everybody to participate through this. And then, of course, as I said, education. So I think this is the way we have to take lessons learned that we've done in the past, particularly quality and safety, to put this in the future. After all, this is about quality of patient care.
Great. Yeah, thank you so much. And I agree. I think there's so many analogies between this and the quality and safety movement. There's a lot to be learned from our experience.
One thing I've said that, when I think about this, the disposables, right? I mean, it's now becoming kind of a way of life, a big industry to, where's the data? I mean, the original data of disposable, of course, is to reduce infection. But where's the data, the way we practice is that really, can we actually practice somewhat differently? That we can actually do a lot more savings and still get the same outcome. So I think that's a research project I'd love to do, right? Looking at, more reusables, less disposable, monitoring what happens to the outcomes, and then change the way we practice altogether.
I agree. And I think there's a question from the audience about this specifically and how we begin to address concerns about infection control that have really kind of driven a lot of this movement towards the increased use of
Right.
disposables, and how to
Yeah.
really kind of begin to address those
Yeah.
concerns.
So this, of course, requires a large scale study. So I'm talking to the funders to fund such a study that you can actually look at, big enough scale to be able to know whether you can monitor a different practice, still having disposable, but not the way that we do this without thinking, to see whether there's any different outcome. And I think if MGB is interested in doing this, send me a note, because I think we need organizers willing to do this.
Great, thank you. A few other questions here. Sorry, I'm just trying to get back to them. A question about kind of not just telehealth, but remote work. And is face-to-face work, meetings, conferences, are they really that important, or should we be advocating for virtual meetings and continued remote work?
Well, I would say it this way. I work in DC. My family lives in Durham, North Carolina. I used to go Monday to Friday to DC, go home on the weekend. COVID resulted in the virtual work environment whereby our team knows each other really well. And now I'm a lot more reasonable in terms of how I go back and forth about 50% time, and I still get all my work done. And our staff are now, this is not a hospital to be sure, we're now really more in the office type work. Our staff are back about 40%. And many places are doing that already. I think the question for healthcare is how much of our healthcare need to be done the way we do this. Having patients drive from Natick to Mass General to have a 15-minute encounter. With virtual care, with AI, we do have to start thinking about how we can change these things, right?
Yeah.
And so along with that would be obviously CMS making sure that, and regulatory agencies to support this. So there's a hospital at home. I'm sure you guys are already starting hospital at home.
Mm-hmm.
And that's usually done because there's not enough beds. But think about this. You're also actually managing patients at home with much less, need for high energy, intensive, approaches. So yes, I think there's a lot of issues. I'm involved with initiatives that are looking at managing diabetes care, taking a good look at how you look at the entire continuum of diabetes care. Can you reduce the amount of testing and travel? I mean, this is really a good place to look at, new care design. And I think this is, in fact, another way. You asked me, Greg, about how you guys can participate. Come up with ideas and then propose it to administration, and if they're willing to support it, or do it as like a research project. I think that's what we need.
We have a number of questions, but I'm not sure we're going to get to all of them. So I want to make sure we address this one because I think it's important for the whole audience to hear. And so many hospitals, including ours, have begun our own initiatives. How do we join the tent as opposed to working locally within our own institutions?
Thank you very much. So we have actually a two-pronged approach in the tent. The first approach is you see it on the website. I think MGB is already part of it, but if not, just simply sign up. If you are, for example, MGH Institute can sign up and say, we want to be part of it. We're just simply saying, just come under the tent. We're following what Don Berwick did in the past. We also, a second prong is we also have X number of hospitals. We have about 50 who say we will measure, we will now start practicing everything. And we have a kind of series of things that we're now designing to say, let's do this, let's do this, let's do this, and start measuring. That is obviously the basis of moving towards a long-term solution that people under the tent can start moving into it when they're ready and comfortable. So my suggestion is first, take a look at our website, sign me and send me an email, and let's talk about how you can join us. Just join it. And then you can, maybe you're ready to do more. We can talk about how to do more, as already presented to you, how the different steps are, and we can work with you.
Great. I think I'm going to try to squeeze in one more question, but in the event that we potentially get cut off at 1 o'clock, I just want to thank you again. But I think this is one more kind of important question. And we talked a little bit about the patient safety and quality. And so this is a question from one of the attendees. Says patient safety affects the individual patient cared for in your institution, but climate change is seen as a public health issue that affects anonymous patients, not directly targeted by your hospital specific care. How do we convince leaders that the general health of a population is worth their investment in fee-for-service financial environment? And I think this really gets to the question of like, how do we move from quality and safety being an issue of like patients under our direct care and beginning to think of quality as something that is relevant to populations and a larger
Exactly.
scale?
Spot on. Population health. Now, you do know that more and more the community is understanding social determinants of health. Certainly, we are all practicing to some extent social determinants as we look at individual patients and the socioeconomic environment. But we also know that the improvement of population requires a total address of socioeconomic issues. I think this is where this very smart, learned person asked this question. I do think that I know that despite the fact we fee for service, I do know that your institution cares about population health. There's a good amount of work done in looking at how to combine, how to integrate healthcare with public health, how to bring data together. This is part of the same thing of population health. You're quite right. So I think you need to push it in the same direction as saying this is also part of population health and eventually help individual patients.
Great. So I think that brings us to time. So I just want to use the last few seconds to thank you again for joining us today. We really appreciate it and all of the work that you and the National Academy of Medicine have been doing on this issue. We think it's really important. So,
well, let me say how proud I am of MGB because, you know, I'm in the same family as all of you. I trained here. I spent a big part of my career at MGB, and I wish you all the luck. And I enjoyed having a chance to meet with you. Hope to see all of you in person.
Yeah.
By the way, the next meeting is in March, I think the 13th, the Paul Farmer Victor Zhao Global Health Lectureship at the Brigham. Please join it virtually or in person.
Yeah, excellent. Great. Well, thank you so much again. We appreciate your time. Everyone, we will be reconvening actually in June. We're taking a couple months off, but we'll be having our next event in June. So we hope to see you then. All right.
Come to our Paul Farmer Lectureship.
Yeah. And to Dr. Zhao's lectureship as well.
Thank you.
Take care, everyone. Bye now.